Hi, this is Tom Fitteman with Ventana Systems. I want to share a simple epidemic model that I developed to wrap my head around how my own community of Bozeman, Montana could get ahead of the coronavirus epidemic. This is what's called an SEIR model. Actually, it's an SEIRD model. That stands for susceptible, exposed, infected, and recovered. But before I explain how all this works, I should mention a couple of things. First is you can download this model from Vensim.com. It's implemented in the Vensim simulation software. You can run it with Vensim PLE, which is free for personal educational use. It'll also be copied at metasd.com. A small disclaimer is in order. I'm not an epidemiologist. I just play one on TV. I'm a mathematical modeling generalist and a careful student of the epidemiology literature. But if you want specific public health advice, you should go find a real expert, and there are lots of them around. Just a quick explanation of the visual lingo here. Each box is a stock or an accumulation of people, and the pipes that connect them represent the flows of people from one state to another. So the process of a susceptible person getting infected, then they're exposed for a little while, but asymptomatic. Then they advance to an active symptomatic infection, and eventually they recover and some of them die. Uh, the rest of the arrows here indicate the causality in the system, the influences that determine how fast these flows operate. The core process is the infection process, which is through this red loop here. So this says if you have infected people, they're out active in the community and they're infecting other people. That creates more exposed people. Those, after a few days incubation, advance to become more infected people. So this is a self-reinforcing process, or a positive feedback loop, or a vicious cycle that grows infection. The speed at which that process operates is governed by this little parameter up here called R0, which is the base reproduction ratio. It's the number of new infections created by an infected person over their tenure in the system. Other processes here, the recovery process, after a certain duration, people either recover or die. That creates this green feedback loop here, for example. So this is a balancing or loop that, left to itself, would cause the infected to drain away. So what we'd like to do is cut off the red loop here so that the green loop can function and as many people as possible can get better. The other thing that's operating is a saturation loop, which says that as we start running out of susceptible people, we have a smaller and smaller fraction of the population susceptible, and we may also get into lower density parts of the social network in society. And that means that the transmission rate is going to go down. So as you run out of susceptible people, the infection inevitably slows down. But we don't want to wait around for that natural extinction to take place. A couple other important processes that are happening here. One is that the reason we don't want to let the infection simply run its course is that the worst case scenario of a completely uncontrolled epidemic is pretty terrible. So here you can see on this chart that the infected population peaks at around 20,000 people at the end of May. That's for an initial susceptible population of 100,000, representing Gallatin County, Montana. And obviously, that's not a good outcome. What happens if things were to get that bad is that the uh, number of serious cases would become large. About 10% of cases, or 5 to 15% in various regions, have required hospitalization. Bozeman Deaconess Hospital has maybe 100 beds. So the strain on the healthcare system to deal with the serious cases would be overwhelming, and that makes the fatality rate go up because people can't get the treatment they need, and therefore you have more deaths than you would if you could keep the infection below the capacity of the healthcare system. The same thing happens on the public health side. This lower orange path is the possibility of monitoring, quarantining, isolating infected people or suspected infected, exposed people in order to take them out of the active infected population, and therefore reduce the extent to which they spread infection to the community at large. But again, if you have thousands of infected people, we simply don't have the public health capacity to do the contact tracing and everything else that needs to happen to make that work. So we have a set of policy levers here which are around isolating the infected, but that loop only works if we have sufficient capacity. So we want to keep the infection below the limits of our healthcare system. Another option for doing that is to lower the transmission rate. And to do that, we have actually a lot of levers, which I've called behavioral risk reduction. That encompasses things like social distancing via either literally standing farther from people or canceling meetings and public gatherings. It's also things like sterilizing surfaces, washing your hands, all the things that kind of fall into the bucket of personal behavior. The trigger for all of this in the model is an import of some infected people from another region. And this happens in a one-shot process, and once you have a few infected people, the infection takes off on its own via the red feedback loop here. So that's an important simplification because we're not challenging the model with an escalating signal as the infection progresses elsewhere in the country. So an important thing to bear in mind here is that this is a model that is a simplification of reality, and there are ways in which it is optimistic and ways in which it is pessimistic. Some other simplifications are, for example, that the infection duration is the same for ordinary or mild cases and severe cases. Another is that people don't lose their immunity, so the recovered are out of the loop. But there could be a flow from recovered back to susceptible. And there also might be some things that give us some help. So let me fire this up so we can experiment with the model. So one possibility is that we get lucky, and there could be a variety of ways that happens. One could be that the density of social networks declines as you penetrate further into them, so that the initial rapid spread is in high risk, high connectivity populations. That's one possibility. Problem is that doesn't help much with the early spread, but it does shrink the ultimate scale of the problem. Another possibility is that out here in Montana, we're a bunch of well spaced out hermits. So maybe we're just a little bit less infectious on the baseline. And another possibility is that summer will come along and coronaviruses don't like heat, so there will be less infection spread over the summer. But everything I've seen in the literature so far says don't count on it, unfortunately. But I'll leave a little bit of seasonality active here. So this is a somewhat arbitrary improved scenario, but it's still basically a health catastrophe. We're now peaking at 10,000 infections instead of 20,000. It happens a little bit later, middle of June, but we still have thousands of deaths in Gallatin County, which are going to be heavily weighted towards the elderly population and people with compromised immune systems. So this is still a catastrophe that we want to avoid. So can we do that? Let's get rid of the worst case here and start from our slightly optimistic scenario. What else could we do? Well, there's the possibility of isolating, quarantining, monitoring infected persons. So, of course, if we could do that with 100% effectiveness, that extinguishes the disease. So, essentially, you take all the infected people and you immediately remove them from contact with others, and that cuts off disease transmission. And so, what you see is the infected population quickly drains away to zero as those people mostly recover. But of course, perfection is not realistic. You have a lot of things working against you. One is just the physics of the system that you have exposed people who are asymptomatic. So when they advance to becoming active, infectious, symptomatic people, you can't find them instantaneously. Some of them may be mild cases. Those are hard to find as well. They get mistaken for the flu or ignored. You also have non-compliant people or people who are under some necessity of working, who may be out there actively spreading infection. So there are a lot of reasons to think that this is not going to be 100% effective. So let's dial this back and actually run this again with a new name. So let's call this isolation. Okay, so here is isolation effectiveness of about 35%. And we could go up, it might even be 50% effective. The problem is we're scaling back the problem a lot and actually delaying the peak as well, which would create valuable time to prepare. But it's still not working. And part of the reason is that you can see that the public health and hospital systems are still strained. So that causes this orange process to kick in, which is there are a lot of infected people, the public health system is under strain, the effectiveness of isolation collapses because there simply aren't enough people available to get out and trace contacts and do all the other things you need to do in order to successfully contain the problem. So unless it's extraordinarily effective or you dramatically increase the resources, this policy is not going to work all by itself. Another key insight is that delay is problematic. I'll scale this back just a little bit. So here it's about 35% effective. What happens if we delay the start? So this reaction time is the number of days from identification of the first patient to ramping up a program to trace contacts and implement quarantine. Uh, as you delay this implementation from 2 days to, say, 2 weeks, you'll notice the infection peak gets taller and shifts to the left. So getting off the dime quickly is really important. So what else do we need in this system? We either need an unrealistic level of isolation and public health intervention in general, or we, as in we the people, need to change our behavior to help out the healthcare system. So our other policy over here is reduction in risk from various behavioral measures. This again is all the social distancing and hand washing and so forth. Okay, so let's try behavior. And I'll leave the isolation measures in place. And now you can see that the epidemic is under control. It's actually hard to see, but it's down here at the bottom of the charts. So that's great. So the reason that we've succeeded is that we've taken the initial conditions where an infected person created 3.3 additional infections during their tenure in that state, and we've lowered that to where they don't replace themselves. So we did that by reducing behavioral risk factors by a little more than a third, and by reducing transmission from infected people by a little over a third by quarantining them. And that's sufficient to extinguish the disease so that the recovery process can be the dominant loop, and it also lets the healthcare system function normally. So if I unload our earlier runs, you can see what's happening. The strain on the hospital system is now just a fraction of their capacity, and same thing for the public health system. That means isolation is effective and people get the best treatment possible, so we have fewer deaths. So this is basically a success, and it's not that heavy a lift. It's not hard to imagine that we could reduce our social causes of spread by a third and succeed in self-isolation and monitoring and all those things by a third. We're not completely out of the woods yet, however, because we've assumed we're getting a little bit lucky on the dynamics of the disease, and that might not be the case. It could be that contact density doesn't really decline much, and it could be that there is no seasonal effect, as some of the reports are indicating. And it could be that the public health response still can't keep up. I actually have no idea what Gallatin County, Montana is capable of doing. And in that case, the infection could take off again. So what we really want to do is sort of socially overreact, because the more we can reduce our behavioral risk, the better we do. the more we're able to withstand these other possible weak links in the chain in the system. And once again, if we can manage a big risk reduction, as apparently occurred in China, though with unpleasant draconian measures, then we do better. And actually, it also helps a lot if we are faster at it. So here's a 40% risk reduction with a 3-week social reaction time from the first case. If we're ready today, that dramatically lowers the course of the disease spread as well. So what's the bottom line here? Well, there are pundits out there who will tell you don't panic. And I think they're right. We are in control of our own fate, and if we work together, we can get from a bad, uncontrolled outcome to one like the green line down here, where the disease doesn't get too far off the ground. But there are also people out there who will tell you don't listen to the epidemiologists because they were wrong about SARS and H1N1. But in a sense, that's the Cassandra's curse of being an epidemiologist. When you point out an imminent threat, society responds, and the threat doesn't materialize the way you predicted that it would. And sometimes you get lucky. But that's not a robust strategy for dealing with these infectious diseases, which are real threats. If you reliably want a good outcome like the green line, sometimes when a disease comes along that's relatively lethal and quite contagious, you may actually have to change your behavior. And I think that's the bottom line here, is that we all need to work together to change our behavior to lower the risk of spread so that the rest of the system, the public health and the hospitals and our healthcare workers, can do their job. But it appears to be pretty doable, and some countries like South Korea have already done it. I guess my personal bottom line at this point is that I'm not going to panic. For one thing, I already have a vast stockpile of toilet paper, but I also don't think I'm at great personal risk of getting infected, and in particular of dying from this disease. I'm one of the lucky ones. But I really don't want to be part of the red loop, passing it on to someone who's more vulnerable than me. So I'm going to do everything I can to stay out of that loop, which means canceling meetings and washing my hands like crazy and everything else. But of course, that's easy for me to say because I work at home anyway. So the disruption to me will be minimal. So the other thing I'll be doing is thinking about how can we soften the blow to people who aren't so lucky, people who work in tourism or simply don't have the economic resources to withstand the disruptions that are coming as supply chains stock out and things like that happen. So really that's the fundamental puzzle here, I think, is how can we all pull together and help one another at a time when a disease is trying to pull us apart? I think that's the great challenge for us. I hope this model helps you to think about these problems, and once again, you can find a copy of the model and the software at vensim.com, and I would look forward to your comments at metasd.com. Thanks for watching.